Hey, Daniel, are you able to hear me? Daniel, I hope you're not in mute. Hey, Jen or Patrick, could you say something? I just want to see if the audio is going through correctly. Hey, Daniel.
Hey, how are you?
Very good.
Okay, perfect. So now we can hear you well where we're at.
I just want to make sure everybody is interactive. So because everything is case-based format, so I'm going to so people are able to respond to me either by chat or by literally talking back on the through the system.
Can you repeat the question? I'm sorry.
No, it's a case-based format. So
okay.
I just want people to be able to answer, the fellows to be able to answer.
Yeah, so with the webinar format where everybody that's in isn't able to comment, so it might be through the chat, but we as the fellows are all collectively kind of in our lecture room, so we're able to watch. We're not on individual computers.
And are the fellows able to call in with the answer?
No, because we're all on. Oh yeah, I'll be able to type it in the chat.
Okay, at least type it in the chat the best you can, and in that way it'll be good. Okay.
Sounds good.
All right. So I'm going to start if that's. I'm going to start if that's okay.
Perfect. Thank you.
All right. Bye now.
Bye.
So good afternoon, everyone, and thank you to Daniel and the rest of the Pulmonary team for inviting me. I'm sorry, I'm a little bit under the weather. I'm unable to join in directly. I guess I got a little bit of the corona bug as well, so I'm in quarantine at home. So moving on, the goal is to talk about pulmonary infections in the immunocompromised host. So we'll start with the case. So this is a patient who presented to the emergency room in mid-March with the chief complaint of generalized body aches, decreased appetite for weeks. And the past medical history is significant for FSGS, status post kidney transplant. Past surgical history, living-related kidney donor from the sister through a pair exchange kidney transplant. Other than that, she had a Roux-en-Y gastric bypass. She takes mycophenolate, tacrolimus, and prednisone for immune suppression. 1 month ago, switched from azathioprine to mycophenolate for tubulitis on renal biopsy. Social history, never smoker, no alcohol or illicit drug use. And obviously, we'd like you to ask much more history. So I'm going to answer those histories. So no pets, definitely no animal exposures. Travel has no recent travel history. Exposures patient reports she rarely waters the plants in her home, and that is the key element here. She does water the plant, and husband does all the gardening and lawn care. She does not live near any fresh water, follows transplant diet. So she has a skin lesion, as you can see, it's painful nodular skin lesion on the left thigh, and on the right side of the neck, there is also a painful node that is very painful. If you look at the labs, the Y count is a little bit elevated, a CRP is elevated, creatinine is 1.36, almost close to baseline. COVID test is negative, otherwise pretty unremarkable labs. Look at chest X-ray, you clearly see there is a right-sided, some sort of a big nodular versus mass-like lesion on the right lung field. If you look at a CAT scan, that sort of confirms that. In addition, you see that in brain MRI as well, you find that there are lesions, multiple lesions in the brain MRI. So now you have a syndrome of a patient who has a painful skin lesion along with lung nodular, lung inflammation nodules and brain lesions as well. So when you have this syndrome, what is the possible diagnosis? And the clue is in patient watering her plants because there is dry soil. And when you try to water, it poofs up and you inhale and you get into trouble. So the answer, other than Michael, because this is his wife's case, Michael Rayman, other than him, if one of the fellows can quickly chat for, I'll give 10, 20, 30 seconds. So this is the summary. Okay, so I hear endemic fungi, Cryptococcus, histoblasto, and I hear crypto as well. And there is some comments for nocardia. So they all seem pretty appropriate at this point of time. They all seem correct. But what is more likely in this patient who hasn't traveled, so you don't want to think about endemic mycosis as less likely. It's not zero, it's less likely. Crypto can happen anytime in a solid organ transplant patient. Nocardia sounds very interesting. Why? Because you have a painful skin lesion along with lung infiltrate and brain. So nocardia does sound interesting. So the differential diagnosis obviously includes things such as branch bacteria, Actinomyces nocardia, rhodococcus, specifically if you have exposed to animals, particularly farm animals like horses, and standard things like Pseudomonas, NTM, MTB, which are very unusual, less likely. Fungus, could this be just plain old Aspergillus? Possible. Scedosporium can actually cause skin infection. But zygomycosis less likely with this combination of illnesses. Demetaceous fungi from soil can do that as well. endemic mycosis if you have visited or in appropriate places. Cryptococcus is a mimicker, can happen in any place. Porothrix is usually painful as well. Rarely people have manifested with EBV PTLD manifesting as lymph nodes, lesions in brain and in the lung. The skin lesion doesn't look very typical. Parasitic toxoplasma, cysticercosis. So all of this possible, but unusual. So and non-infectious PTLD we talked about a little bit. And of course, you don't want to miss cancers. So the pathology from the skin, lung, they all grew the same branch bacteria. And this turned out to be disseminated nocardiosis. So great job. And it's special nocardia because this is a Nocardia thailandica, and we won't go into that at this point of time. So going into the talk, which is also going to be case by case and stuff like that. So we're going to approach infections in immunocompromised patients, discuss infections associated with immunomodulated therapies, and then we'll try to see if we can talk about some timelines of infections in transplant patients. So if you look at host defenses, infections associated with damaged skin mucosa is a possibility. Neutropenia, then cellular immunity, humoral immunity, or splenic dysfunction. So let's start with another case. A 50-year-old male with acute myelogenous leukemia developed a fever for about 6 days after induction chemotherapy. Patient noticed pain around the Hickman catheter. This is not a pulmonary infiltrate question, but I think it's important for you guys to be aware anyways. Most of the cases are pulmonary infiltrates, but this one is not. Temperature of 101.8, heart rate of 100, blood pressure 130 over 80, severe oral mucositis. There is erythema at the site of Hickman line. The rest of the exam is normal. Y count is low at 400. The empiric antibiotic therapy for this patient, and if you can chat quickly. So somebody said cefepime, and the answer is actually cefepime plus vancomycin, because normally we would just do cefepime in a patient, but when the Hickman site is suspicious for infection, and then you don't want to miss staph. Otherwise, you're absolutely correct. Cefepime is the only answer, but in this case, it's cefepime plus vancomycin. So what is the problem here? There is a skin defect, a central venous catheter. So the classic organisms there are going to be Staph aureus, coag-negative staph, and sometimes gram-negative bacilli such as Pseudomonas aeruginosa, E. coli, or gram-negative, other gram-negative bacilli, certain fungi such as Candida. When you don't have skin defect, you only have this mucositis, then you're going to look predominantly gut-related translocation. So gram-negative bacteria, oral mucositis, viridans streptococci, and oral anaerobes. Fungi, because it's mucosal reactivation, Candida, and viruses such as HSV, such as because it's mucosal reactivation. So going to the next question. This is a 22-year-old woman with aplastic anemia, received an allogeneic stem cell transplant 9 days ago. And she develops fever and a tender skin lesion and infiltrate on chest, and she also has a vague infiltrate on chest X-ray. WBC count is 100. What is the best test that will provide the diagnosis? Please chat. So somebody said skin biopsy. Skin biopsy will probably give you the answer. You're right. But the answer is actually blood culture will give you a far better answer. The name of this condition is ecthyema gangrenosum. Ecthyema gangrenosum. So now you know, as soon as you know ecthyema gangrenosum, you know the organisms are going to be plenty, but particularly Pseudomonas is known association with that. And it can also cause lung infiltrate as well. So the problem with neutropenia, so when the defect is neutropenia, and it's caused by chemotherapy-induced neutropenia, such as chemotherapy for leukemia or hematopoietic stem cell transplantation, then you're going to have a bacterial translocation, typically from gut, but sometimes from the skin. So you want to look at organisms such as gut organisms, E. coli, gram-negative bacilli, Pseudomonas, or gram-positive cocci such as Staph aureus, coag-negative Staph, Viridae, and Streptococci, fungi, Candida, and rarely Aspergillus and molds, and viruses such as HSV. So why is that important? Is because these are important because your prophylaxis is directed against them. So in the high-risk patients with leukemia and HSCT, where you're going to have prolonged and profound neutropenia. Prolonged means greater than at least 7 days. Profound, as to the anticipated duration of neutropenia, is at least 7 days or more. Profound is at least if your neutrophil count is less than 100 or more. So when you're prolonged and profound, then you are generally going to give prophylaxis for that patient. This is only chemotherapy-induced neutropenia, not people who have aplastic anemia or MDS who are probably stable neutropenia. This is post-chemo-induced neutropenia because there is failure. The biggest failure with chemotherapy-induced neutropenia is mucositis. So that's called mucosal barrier injury. So it's very important that you have not only neutropenia, you need to have additional mucosal barrier injury. So in those cases, we tend to give prophylaxis for bacteria such as ciprofloxacin or levofloxacin, fluconazole, and acyclovir. So going to the next scenario, a 38-year-old man with ulcerative colitis on therapy with infliximab, so a TNF-alpha agent, and prednisone, and the prednisone is being tapered. He's admitted with a 2-week history of progressive dry cough, fever, dyspnea. PPD was negative. Temperature 102.2, oxygen saturation 94% on room air, bilateral basal RALs, WBC is normal. Ceftriaxone azithromycin is empirically started. Patient, over the next 2 days, the hypoxia worsens. You see the chest X-ray finding, and please chat for your answer. So the answer seems to be bronchoscopy with BAL. So the diagnosis is, can anybody say what the diagnosis is? Somebody gave a differential diagnosis of possible NTM, dimorphic fungi, Burkholderia, Salmonella, and the answer, in this case, I'll tell you what the answer is. PCP, that's the right answer. Absolutely. PCP. So see, the problem here in TNF-alpha dysfunction is it's an interface problem. There is a problem of the immune system interface where the side TNF-alpha, what it tends to do is you have macrophages and dendritic cells, macrophages. These take up pathogens. They engulf pathogens. And then what they do is they are not able to control it consistently. So they sort of hold on to it like thieves. They hold on to it, but they're not able to completely put them down. And so they do what is called as a danger cytokine signal. And the danger cytokine signal is TNF-alpha. And the same thing happens with inflammatory disorders. And so when you try to block the TNF-alpha and when you get exposed to certain infections, that danger signal is not there. So the TNF-alpha recruits more T lymphocytes and other lymphocytes, and that walls off and forms granuloma. So it makes sense that if you use a TNF-alpha blocker, you're going to knock down any granulomas, and you have significant granulomatous infection-related problems. So whenever you see TNF-alpha blockers being used, your answer or suspicion is going to be any granuloma, any infection that forms granulomas, granulomatous infection. I'll give you a list of them. So the list is going to be things that in bacteria, the list is going to be TB or mycobacterial infections. And in fungi, it is going to be mostly endemic fungi, such as cystoplasma, that kind of stuff. In this case, it's a combination of things. In T cells and TNF-alpha, everything was included. So that's why it has a broad thing. But for practical purposes, whenever you consider TNF-alpha, I'll talk a little bit more about TNF-alpha as we go down the road. Here it is about T cell dysfunction, where they are talking, because the reason why they put T cell dysfunction here is because in addition, there was steroid therapy that was being tapered down. So that's why T cell dysfunction came in. So PCP, when it comes to T cell dysfunction, PCP comes very high on the fungi category. Then comes things such as Cryptococcus or Aspergillus. In bacteria, it is TB or mycobacteria. And then don't forget intracellular bacteria such as Nocardia or Legionella, and viruses such as VZV, CMV, HSV, and then Toxoplasma. So the answer here is you should consider PCP prophylaxis with trimethoprim sulfamethoxazole in patients on chronic steroid therapy greater than 20 milligrams per day for greater than 30 days, especially if underlying immune deficiency. Particularly if there's a combination TNF-alpha additionally, you want to seriously consider prophylaxis. A 64-year-old man with multiple myeloma has 2 previous hospitalizations for sepsis, and he's admitted with 1-day history of fevers and chills, and he always gets pneumonias. He appears toxic. Temperature is 102.6, blood pressure is lower, 90 over 60, heart rate is 110, respiratory rate is 22, and mild pallor, no other abnormalities on examination. The blood culture obtained in the ED is likely to grow which organism? Please chat. The blood culture, no. The blood culture is going to go strep pneumonia. Remember, multiple myeloma, the immune deficit is B cells. So in principle, while I'm on this stage, let me tell you, in principle, when you look at adaptive immune system, you have the T lymphocytes and B lymphocytes for practical purposes. Th1 is the T lymphocytes, Th2 is the B lymphocytes. Th1, T lymphocytes, you're looking at intracellular pathogens. So if there's any deficit of T lymphocytes, you're looking at intracellular pathogens, viruses, and certain unusual bacteria such as Legionella, Listeria, that kind of stuff. Whereas if you're looking at extracellular pathogens in adaptive immune system, B lymphocytes, those are the major things. So you're looking at bacteria. Those are the things that will affect it. And the most common bacteria that tends to cause trouble when you have immunoglobulin deficits and related stuff is encapsulated bacteria. So strep pneumo becomes the #1 bacteria there. So when you have impaired humoral immunity, B cell, multiple myeloma, chronic lymphocytic leukemia, or immunoglobulin disorders, or compromised splenic functions such as sickle cell disease, asplenia, HSCT, you tend to have bacteria such as encapsulated bacteria, strep pneumo, Haemophilus influenzae, or Neisseria meningitidis. So generally, your answer to this is you should try to immunize them ahead as much as possible against strep pneumo and influenza. And if they continue to get recurrent infections, then we may consider secondary prophylaxis on a special case-by-case basis. So, what is happening here in these disorders that you can see is the signs and symptoms of infection are often muted. The differential diagnosis is usually broad. Diagnostic test results are not readily available, and they generally rapidly progress to infections. So empiric therapy needs to be kept in mind based on what your knowledge base on these things are. And selection of diagnostic tests also depends on your differential diagnosis. And identification of prophylaxis and immunization depends on what potential immune deficit is there and how long is the immune deficit going to be there. And that determines duration of prophylaxis and appropriate immunization as well. Then going specifically into TNF-alpha therapies, you have several. Nowadays, there are plenty of them, but I'll talk about some of the older ones. Etanercept, infliximab, adalimumab, and Simponi, golimumab. And etanercept alone is slightly different. It's a soluble TNF-alpha receptor fusion protein. The remainder are monoclonal antibodies against the anti-TNF-alpha. And they're used for various other disease processes, including several rheumatologic disease processes, psoriasis, and GI disease processes such as IBD. So there is increased risk of intracellular pathogens, particularly pathogens that tends to cause granulomas and stuff like that. So in bacteria, Mycobacterium tuberculosis, Listeria can be there too, Legionella, Nocardia, fungus, pneumocystis, but mostly histoplasma and coccidioides only if you're living in the Arizona, in that southwest region of United States. Cryptococcus neoformans, aspergillus can happen as well. So if you look at risk factors among the TNF-alpha agents, you realize that infliximab, the older one, infusion, has much more higher degree of reactivation of tuberculosis compared to etanercept. And similarly, you go down the list, everything seems to be much more higher, particularly histoplasma, Listeria, non-tuberculous mycobacteria, aspergillus, cryptococcus, nocardia, salmonella. Everything seems much higher with infliximab compared to etanercept. So it's not surprising. So temporal distribution of granulomatous infections during treatment with etanercept or infliximab, you find that most of these infections happen within the first 90 days of the initiation of the TNF-alpha agents, within the first 3 months of initiation, whether it's etanercept or whether it is infliximab. So now moving on to another TNF-alpha question. This one is not a GI problem, but I'm sorry, not a lung problem, but something a GI. A 43-year-old a woman with ulcerative colitis failed standard therapy, started on infliximab with significant improvement of abdominal symptoms. 2 months later, developed abdominal pain. So within that 3 months window, low-grade fevers and weight loss, and has pretty matted lymph nodes on the abdominal X-ray. So the clinical radiographic picture is most consistent with, I won't have to ask you this, but the answer is pretty straightforward. It is tuberculosis. So the extrapulmonary TB can happen in people on TNF-alpha agents. It doesn't have to be in the lungs. So the risk is clearly more with infliximab compared to adalimumab, and the least is etanercept. And the highest risk seems to be within the first 3 months of TNF-alpha agent use. An increased risk of extrapulmonary TB and disseminated TB can happen. So what are you supposed to do? You screen all patients for TB before starting any TNF-alpha therapy. You do by examination, do you do by an IGRA assay? And if they are positive, then you have to treat for latent TB. And standard therapy with INH for 9 months, but now we have newer therapy for LTBI. We can use any one of them. But if your TNF-alpha needs to be restarted because the patient has active disease, when can you restart? When you have an underlying history of latent TB and you've just started treatment for latent TB. So the answer is you can do it approximately about a month later. 1 month after initiation of treatment for latent TB, you can restart TNF-alpha, but you have to complete the treatment for latent TB as well. And obviously, you need to educate the patient to watch out for symptoms of reactivation of TB. Now, a 52-year-old male with severe rheumatoid arthritis on prior therapy with steroids was started on infliximab 3 months ago. PPD was negative. He develops a progressive cough with productive sputum, low-grade fevers, and right-sided pleuritic chest pain. So it's very important to understand pleuritic chest pain. And the most important diagnosis is you can see there's an infiltrate on the right lung, and you are growing something on the culture of the respiratory culture. Now, please chat. So people said actinomycosis. Actinomycosis is a chronic disease. Even this one, it's not an acute disease and stuff like that. So I would keep it less. Nocardia is the answer here. This is actually nocardia and stuff like that. And if you look at the, I mean, obviously, if you look at it, it's actually beaded branched bacteria, and that is classic for nocardia. So if you look at other pathogens, other than the granulomatous pathogens, we told you that there's an increased risk for Legionella pneumonia, and based on FDA warning, because 80 patients developed post-infliximab, 14 people died, and median time from TNF-alpha was about 10 months, and 65% had rheumatoid arthritis. And subsequently, there are many more cases. Same with listeria and nocardia infections as well. So suspect. So you have to suspect Legionella, listeria, nocardia in patients on TNF-alpha, so you can get the appropriate diagnosis and treat them appropriately. At this point, we are not recommending any standard prophylaxis for these bugs at this point of time, because they are still uncommon. Now, a 63-year-old woman from Indianapolis with rheumatoid arthritis has been started on therapy with steroids followed by adalimumab, another TNF-alpha agent. 4 months into the therapy, she develops malaise, fevers, sputum and blood cultures are negative. Now, what do you see? This obviously is a fungal stain. So please check. So the answer, one said PCP, one said histo. So if you look at the organism there, it may be difficult for you to see from what I'm projecting, but it actually has small spikes on the surface, and that is very classic for histoplasma. So this is histoplasmosis. So the fungal infection associated with TNF-alphas, there are plenty of cases with pneumocystis, histoplasma. So there's a black box warning label with histoplasma. And there is obviously in the other endemic region, coccidioides. You can still get other standard fungal infections, cryptococcus and aspergillus as well. So you want to be aware about these things. So you want to suspect histoplasma, coccidioides, cryptococcus in patients on TNF-alpha therapy, along with the epidemiological risk factors. In this case, the person was in Indianapolis, so Midwest, much more higher risk of histoplasma in farming areas. And you want to perform the appropriate diagnostic test. And then consider PCP prophylaxis in patients on TNF-alpha inhibitors, especially if they are on addition of steroids. You want to consider PCP prophylaxis. So, what do you, in bacteria, you want to untreated infections or patients on antibiotics for ongoing infections, untreated TB or latent TB, you want to avoid TNF-alpha till you sort of settle them down. Acute hepatitis B or C, chronic hepatitis B or C, active varicella zoster infection, or active systemic fungal infections, or non-healing skin ulcers. So in these kind of agents, you want to make sure things are taken care of or treated before we initiate TNF-alpha. In latent TB alone, you can restart TNF-alpha 1 month later after initiation of treatment for latent TB. A 36-year-old woman with multiple sclerosis is on therapy with natalizumab, Tysabri, integrin receptor antagonist. Integrin receptors are basically, as the neutrophils sort of marginate into your blood vessel, what happens is that they need integrins to sort of adhere to the walls of the blood vessel, then they can go into the tissue. When there is any problems in the tissue, like there is infection or something, you can go and attack it. So that's what integrins are needed for. And that's an integrin receptor antagonist. So 2 years after therapy was initiated, she noticed progressive difficulty in concentration, weakness of the left lower extremity, loss of balance, and was admitted to the hospital. And you can see what is there on the, there is diffuse periventricular findings on the MRI. So lumbar puncture was done. The test, you will order the CSF, order CSF that will most probably like the diagnosis is, if you can chat, in this case, the diagnosis is PML. PML, so it's JC virus. Yep, that's right. So 212 confirmed cases of PML. This was a while ago, 2012. Out of about 100,000 people treated. Overall incidence is 2.11 per 10,000 patients. PML risk can be stratified by 3 risk factors. If the duration of treatment is longer, duration of the tisabri treatment, prior immunosuppressive use, additional of other immunosuppressive use, or if you do JC virus serology and you're already positive, then your risk is considered high, meaning your risk of reactivation of JC is greater than 1 in 100. If all 3 risk factors are present, it's low. If the JC virus serology is seronegative, the risk is only 1 in 10,000. So you want to keep that in mind. So for TNF-alphas alone, screen and treat patients with LTBI before initiating TNF-alpha. You want to consider opportunistic bacterial and fungal infection and differential diagnosis of infections in TNF-alpha. And JC virus associated PML can occur in patients on natalizumab therapy. Now, finishing up with transplant. So let's talk about transplant here. A 58-year-old male had received deceased donor kidney transplant 8 months ago. He was admitted with a 2-week history of headaches and altered mentation. Chest X-ray had right lower lobe infiltrate. CSF findings showed elevated protein. Glucose was 48. WBC count was 214 with 64% lymphocytes. What is the most likely cause of meningitis? Please chat. Somebody said strep pneumo. Anybody else? It's a lot of lymphocytes on CSF. Crypto, that's right. Crypto is your diagnosis, crypto. So let's talk about what happens in transplant to get to the diagnosis. So if you look at this timeline, we divide, we are looking at solid organ transplant. We had, and this has not changed really in decades now. It's pretty much similar. With we divide transplants into 1 month after transplant, month 1 to 6 months after transplant and beyond. Why do we divide that way? As the first month, things happen differently. And then from month 1 to 6 is where the intensity of immune suppression, particularly T-cell immune suppression, is higher in these patients. So in most solid organ transplant, the predominant immune suppressive targeting is on T-cells. So you're looking at predominantly intracellular pathogen prophylaxis and intracellular pathogen reactivation. So that's what you'll be looking at predominantly. And then with time, after 6 months, if all goes well, with there's no rejection and stuff, then what happens is you tend to become more like community-acquired infections. So what happens in conventional infections in the first month, you're only looking at typical surgical infections, such as wound infection, UTI, pneumonia, and that kind of stuff. Rarely you can get a donor-derived infection. I had a patient who was admitted post-liver transplant about 6 weeks into his admission, and this is 6 weeks after liver transplant. He complained of severe thigh pain, and we go and eventually image and then aspirate the thigh. It's nocardia. And then how did he get it? We thought it could be donor derived. In this case, it was actually he was a gardener and an intense gardener, and so probably this was brewing in him. It just become reactivated early, so that's very unusual. So predominantly, what you're going to see is rarely you'll see donor-derived infection, but predominantly on the first month from solid organ transplant. In solid organ transplant, you're only looking at hospital-acquired healthcare associated infections such as wound infections, C. diff, device infections, pneumonias, UTIs, that kind of stuff. 1 month, it takes about a month for the immune system to slowly wane down and become truly immunosuppressed. And this is T cell suppression. So T cells means intracellular pathogens. So for month 1 to month 6, you're looking at, you are predominantly looking at viral infections, such as because intracellular pathogens. So you're looking at VZV infection or EBV infection or CMV infection, and rarely, sometimes you can get Hep B or Hep C reactivation. In the right season, you may get respiratory enteroviruses, but predominantly you're looking at CMV, EBV, or VZV infection. That's why we prophylax for VZV and CMV. Where if you're CMV negative, then we prophylax for VZV with high dose acyclovir or valacyclovir, and if you're CMV positive in one of the any mismatch or donor positive or recipient positive, then we are giving appropriate CMV prophylaxis in the setting. Similarly, we tend to get other infections such as nocardia, listeria, maybe TB reactivation in the right setting. All this happens. You start to get opportunistic infections such as pneumocystis, aspergillus, Cryptococcus, and Candida can cross over. From early to this one, because Candida can be a surgical infection or can be an opportunistic infection. And then depending on where you are, you can get endemic mycosis. Rarely you get toxoplasma reactivation, or where depending on where what exposure you had, you can get strongyloides, leishmania, trypanosoma. So, so the opportunistic infections are typically happening at least a month later, and up to 6 months or a little bit longer. But as the immune suppression wanes down with time, as the solid organ transplanters try to cut back immune suppression, then the patient, the host, becomes more like a regular host. Then you're looking at conventional infections, such as community-acquired infections or persistent infections. Or rare infections such as PTLD. So you can get CMV still, you can get late onset CMV or EBV related PTLD. And the infections that seem to happen anytime in solid organ transplant, even a few years out, even though immune suppression is minimal, are infections such as Cryptococcus. And so don't forget Cryptococcus, Listeria, and Legionella. And these 3 infections seem to happen even a few years out of transplant, even though when you're on relatively small amount of immune suppression. So now let's go to the last. So this sort of tells about prophylaxis correctly. Now let's go to a hematopoietic stem cell transplant. A 54-year-old woman that received allogeneic hematopoietic stem cell transplant 4 months ago. She's on high-dose steroids for the treatment of acute graft-versus-host disease. The patient is admitted with low-grade fever, cough, and left pleuritic chest pain. And now the most important cause of a symptom are, and this one you got to get it right. If you get this wrong, I have to talk to Dr. Tatum about this. Come on, guys. Common is still common. Yep, aspergillus is the right answer, aspergillus. So good job. So let's look at hematopoietic stem cell transplant. Once again, they have a different timeline. So when it comes to hematopoietic stem cell transplant, what happens? So, what happens in a stem cell transplant is you are giving conditioning regimen like day minus 7, 6, somewhere like that. And that tends to drop down all your counts. And then eventually you're doing infusion of the stem cell on day 0, and then day plus is the subsequent phases. And then engraftment is actually neutrophil recovery is defined as engraftment. If your neutrophil recovers for if the ANC is 500 or more for 2 days in a row, 48 hours, then you're considered engrafted. So, and typically engraftment varies between how much insult you had, how many types of chemo you've had, what type of transplant you're going through, allogenic versus autologous transplant. So, and all those things that happen. So when you look at early phase, you can approximately about 0 to 30 days is approximately, say, pre-engraftment. Most of the time it's about 21 days. Phase 2 is about 1 month and beyond, up to 100 days, so 3 months. So that's where you're going to get acute GVHD and related problems. And phase 3 is basically the chronic GVHD and other things. So what happens when you look at the immune system? So when you do conditioning regimen, so close to day 0 and day plus 1, 2, or 3, from that time point, what is happening is your conditioning regimen, basically chemotherapy, is knocking down all your cells. So basically it knocks down innate immune cells such as neutrophils, and so everything becomes 0. And then it knocks down T lymphocytes and also B lymphocytes. So they get knocked down, and they all go down to 0 at this point. And then the first thing that recovers is neutrophils, and that happens within 2 weeks to about 4 weeks. So that's why the 30 days. So that's engraftment. Engraftment is innate immune system recovery. That's what engraftment is. And subsequently, the B cells start to recover in about 3 months, and T cells start to recover in about 6 months to 2 years. So you want to remember that. So what happens during neutropenic phase? In addition, there is, because of chemotherapy, there is mucosal barrier injury. So neutropenia means neutrophils, when it comes to innate immune system, targets predominantly bacteria. So predominantly what you're going to have is a gut leak. So gram-negative bacilli prophylaxis, viridans streptococci because of mouth-related mucositis, and then line-related infections such as staph epi or something like that happens. But when it comes to Candida, that is also mucosal barrier injury-related reactivation, and then HSV also mucosal barrier-related injury-related. So that's why we prophylaxis with Cipro or Levo, we prophylaxis with fluconazole, and we prophylaxis with acyclovir. For the HSV thing early on in the first, before pre-engraftment, we do it. How long do you prophylax? You prophylax until engraftment. So that's what you tend to do. But we need to remember that in the high-risk transplant patients, what happens is there is an increased incidence of mold infections. So we have nowadays moved on from fluconazole to voriconazole because it covers both yeast and mold. So in high-risk transplants such as leukemias, maybe allogenic bone marrow stem cell transplant, you automatically move on to give voriconazole prophylaxis, or AML chemotherapy. We give voriconazole as prophylaxis instead of fluconazole. So that explains the aspergillus infections here. But once you've engrafted, what happens is there is no more innate immune problems. Innate immune system is recovered completely. Neutrophil recovery is there. So meaning you're not interested in prophylaxing for any gut leak or mouth organisms, none of those things that you're in. Now the problem is B cells and T cells at this point of time. Both have not recovered yet. It takes 100 days for about B cells to recover and many more months for the T cells to recover. So now you have risk factors such as PCP, Aspergillus. So you're not going to give PCP prophylaxis before engraftment. You're going to give PCP prophylaxis after 30 days. After engraftment is when you give PCP prophylaxis. After 30 days is when you're going to give mold prophylaxis. And CMV, we do prophylax, but the problem is the prophylaxis itself causes severe cytopenia, such as valsite. So we try to avoid it, except in we have a newer prophylaxis, letermovir. In selected patients, we use that. EBV, we monitor. We monitor for EBV, particularly if we received a lot of thymoglobulin as part of the conditioning regimen and GVHD prophylaxis, then we do monitor for EBV reactivation in the bone marrow setting and stuff like that. We also prophylax for VZV. As I said, we don't prophylax for CMV, but we prophylax for VZV. Why do we do that? It's like because VZV reactivation happens, and VZV is a T cell based disease, and so we bump up the acyclovir from 400 twice a day to 800 twice a day, or valsite from 500 once a day to 500 milligram, not valsite, valacyclovir, 500 Valtrex, 500 once a day to 500 milligram twice a day after engraftment. So those are things you want to remember is what is happening in various stages of illness, why certain things are modifying. Depends on their immune system. So, patients receive prophylaxis during the high-risk period for this one for pneumococcus, where we prophylax when they are on additional GVHD treatment. If they are on GVHD treatment additionally with steroids, then we actually prophylax for pneumococcus, because in addition to T cell immune deficit, the B cell immune deficit is enhanced more by addition of steroids. So we do prophylax with PenVK. PCP prophylaxis happens after engraftment. Aspergillus prophylaxis with posaconazole or voriconazole does happen post-engraftment. We do that. We give it during the neutropenic phase as well. And zoster, acyclovir prophylaxis happens as well. So the timeline of infections after transplantation happens to be specific defects of immune system. This pattern may be impacted by the use of antimicrobial prophylaxis. Obviously, antimicrobial prophylaxis will shift diagnosis, so you need to remember that. Understanding this timeline helps direct the management of infection. I think that's my last slide. If anybody has any questions, they can either chat or if the fellows want to call me directly on my phone, I'll answer, I'll put it on speakerphone and answer. All right, if there's no questions, I'm going to end the meeting, if that's okay with everyone. Daniel and the fellows, is that okay? I'm going to end the meeting. All right, thank you. Please email me if there's anything, and I'll be happy to email the slides to you guys too. Thank you.